Everyone. This is the National Rural HIT Coalition meeting again. I want to go over the agenda because it's as usual pretty full today. Neil Nurnberger is going to start off, who's with Health Tech Strategies, basically giving us an update on policy considerations. HRSA updates as usual. Mike McNeely is going to be here from HRSA's Office for the Advancement of Telehealth, OAT. And then Jeff Mitchell is going from Fletcher, Harold, and Hildreth is going to tell us more about infrastructure and broadband update. And I assume, Neil, you and Jeff are going to coordinate your policy updates. And then we're going to look at something that I think is of huge interest here. We've invited Jessica Duke and Donna McHale from Huron Consulting Group to talk to us more about industry-based telehealth and the impact on rural health. What is happening as businesses across the country are seeing telehealth as a huge solution to a number of their issues and problems. And I was fortunate enough to see Jessica and Donna's presentation for something they did for us at the National Rural Health Resource Center. We have a project that we're working with the Delta region, and basically they did a webinar that I just thought was terrific, and also kind of what I thought was of huge interest for those of us that are advocates for rural health. So Jessica and Donna are going to present that presentation or version thereof. And then we're going to try to save about 10 minutes at the end from 3:05 to 3:15 so that some of you may want to ask questions, or you may want to give a report, or just basically time for the members and the participants to tell us about something maybe happened in your state or anything else you'd want to talk about. So again, welcome everybody. And Neil, I'm going to turn things over to you so you can give us our state and federal HID and telehealth policy and regulation updates.
Great, thanks so much, Terry and Nicole, Sally, Andy, Mike, our other speakers, and our regular attendees, Brock and the rest. I'm going to keep this to about 10 minutes, which is unusual for me, as those of you who know me, but have promised to do so. So real quick, a lot of major initiatives that we're going to have to start parsing through to figure out kind of what the implications for telehealth, remote monitoring, information technologies in health are going forward, but they hold a lot of promise, starting with, and I'll talk just for a second about President Biden's $2.3 trillion infrastructure plan, which among other things calls for $100 billion over 8 years to ensure every American has broadband access, and that we start to reduce the cost of broadband for lower income individuals, folks in rural areas, to make it that much more affordable. We know there are like 30 million Americans, including 35% of rural Americans, that really don't have access to broadband right now. And so, and Jeff Mitchell from the Shelby Coalition may want to help comment on that a little bit later on in the agenda. 4 days ago, the Biden budget was released for fiscal year 2022, $1.5 trillion. It's starting to sound like not much money anymore, given all the COVID relief money and the infrastructure plan. And now the budget's almost small by comparison, isn't it? But it would include a 23% boost to HHS programs. And we'll have to see as that unfolds what it means, you know, for HRSA and the Agency for Healthcare Research and Quality and NIH and all the rest, including those portions that Mike and company have domain over, having to do with HIT in rural areas. In terms of appropriations, we'll know much more about what the labor H appropriations what are called 302B allocations start to look like in the next couple of weeks in terms of the amount of funding within that budget that's allocated for HHS, education, labor, and the related, 58 state agent or the related agencies within that bill. But for now, the takeaway on appropriations is that for the first time since 2010, the House Appropriations Committee is going to allow requests of 4,300 earmarks. That is up to 10 per member, 430 some odd members of the House. And they're going to parse through all of those. This is the return of earmarks in the Biden administration / democratically controlled House and Senate. And that was made available or opened up to members of Congress to make their requests on March 29th. And that deadline has been extended for members to go on the web, on the internet, and fill out some forms that are very prescribed by April 28th about what their requests are for member projects. The reason they're doing this is to make members more accountable for their votes, to ensure discipline, and to ostensibly gain some bipartisanship around the appropriations process. When I worked on labor H appropriations, 20 years ago, it was a pretty well unstated rule that if you got things in the bill and you were a member of the Appropriations Committee, you fairly well had to vote for that bill, at least out of full committee, if not on the floor of the House. And I think that is really the political aim here, is to ensure that ours will vote for the bill or risk having those provisions that they got stuck in there removed somewhere along the process, if not by the House, by the Senate and by Senator Leahy's Appropriations Committee. Okay, enough said about that. Last week was the ONC Annual Meeting. I just sat in on parts of it. It was all virtual. Mickey Tripathi, Dr. Tripathi, who's the new head of ONC, who we were fortunate enough to have on our Rural HIT Coalition meeting in February, gave a really good overview about the agency's role in responding to COVID-19, about how ONC is going to start striving more for health equity through the use of health IT, or what he calls equity by design, about advancing interoperability of health information, including removing, including the information blocking rules and transparency rules and things. And then finally about reducing the burden of HIT on clinicians. And there were a number of panels having to do with the persistent and ongoing inequities in healthcare, unlocking the full potential of healthcare data, how to reduce those burdens on clinicians, a showcase of promising tech solutions, and an effort to recognize leaders in the HIT community. On February 23rd, Senators Scott of South Carolina, Schatz of Hawaii, and Shaheen of New Hampshire reintroduced their bipartisan Telehealth Modernization Act that would update coverage restrictions and give some permanency to the emergency expansions of telehealth for Medicare beneficiaries that have been enacted, during the pandemic. It would update telehealth coverage rules, provide further authority for temporary emergency waivers, especially given the tremendous uptake in 2020 of telehealth consults under the department's, emergency authorizations and waivers and things. Would continue to allow access to telehealth by physical therapists, speech language pathologists, and other providers, give Medicare recipients a whole host of telehealth services, eliminate some of those geographic restrictions, and more. A couple other bills that I won't get into, but we'll take up later in further discussions of this group. Real briefly, and I know Jeff's going to want to talk about this more, on March 30th, the FCC announced round 2 of its COVID relief telehealth efforts, which basically adds about $249 million to build on the $200 million that was made available initially last year as part of the CARES Act. So that's a huge bump in the telehealth program at the FCC. And just you'll want to let all of your constituents know of that availability. And Jeff may be able to tell us more about how to, access all of that and get into it. CMS has, as of April 8th, added 24 new codes for temporary telehealth coverage having to do with audiology and speech language pathology services. And then finally, I would just say that MedPAC met in mid-March, and as part of its annual report to Congress, suggested that we temporarily continue many of the telehealth flexibilities that were allowed during the public health emergency for at least a limited time, for either 1 or 2 years, as we make a concerted effort to gather more evidence about the impact of telehealth on care access, quality, program spending, and the like. So I think that that will give a boost to legislation like the Schatz bill and its companion in the House, and other similar measures as they wend their way through Congress. We've talked about in past meetings the need to have an evidentiary kind of system in place here, so that we don't get hoisted upon our own petards at some point by having malefactors and disingenuous providers and others, providing telehealth services, and the Justice Department and others start to get into it even more than they have been recently. There have been some waste, fraud, and abuse kinds of efforts going on in our field. And I have a sneaking suspicion that this last year has opened the door to potentially more of that. So we would all do ourselves well to document as much as we can, gain as much evidence as we can, and as much funding for organizations like the Agency for Healthcare Research and Policy, CMMI, and others to know what works, what doesn't, under what circumstances. And I will stop with that and turn it back to my colleague, Terry. Thanks so much.
Thanks a lot, Neil. If we have questions, we can kind of save them to the end here, but we appreciate that update. There's so much happening. Mike McNeely, I believe, is here to do a HRSA update, and Mike is with the Office for the Advancement of Telehealth, as you folks know. And Mike, I'm going to turn things over to you.
Thanks, Terry. I will touch on one thing that Neil just said, and basically the look at fraud and abuse at CMS. That's been a sticking point for them for quite a while now, and it did not help the OIG report that tried to link telehealth to the fraud and abuse. In reality, it was more of teleservices. It wasn't actually telehealth that was in play, that they were seeing that in. So understanding where it's coming from and telling a good story is the thing that needs to happen. Other things that are happening, for example, like in Maryland today, Hogan just signed a bill authorizing audio only for telehealth services. That is the type of thing that Neil was describing that was recommended within the MedPAC report for specifically looking down the line for piloting for a year or two after the PHE. There are certain aspects, and the MedPAC said certain telehealth services. So I wouldn't expect all of them to go into pilot. I would expect some of them that they are looking at more so when it comes to really looking at the things that they're tenuous on, like that would lead to fraud and abuse. That is the number one reason why they don't like audio only, even though it's one of the best things for behavioral health and one of the best things for ACOs and doing wellness checks. So understanding that If they were to retract audio only, the behavioral health community would probably go up in arms, to be honest. And that's the type of response that would get a change. That's what would have to happen. Things going on at HRSA, we are still working with USDA and FCC as part of our MOU that was signed in September. Currently, we have been focused on the emergency broadband program that they have announced, which is a $3 billion program that is essentially the Lifeline program on steroids. That program hasn't, the applications a date hasn't been set yet, but we're expecting that to be at the end of the month. We have been preparing the telehealth resource centers specifically to help healthcare providers, FQHCs, critical access hospitals, and RHCs to help with this process. It is designed as a consumer option, so that is a big thing. That program itself will be active until the funds are expended. That $3 billion can go quick. Some of the bills that are out there right now, which I've seen, would put some more money into it at a later date, but there would also have to be some transition going in between once it ends. So there has to be some sort of planning this along that. But I would expect towards the end of April for something to come out officially for the application process on that. Also, we're working with USDA on their $550 million that was part of the, I believe, the Rescue Act. And they are looking for solutions at rural housing services. And so we've been brainstorming with them and providing some content. So I would expect some opportunities coming from USDA. They do have a 150-day mandate to get a notice of funding opportunity out from the end of the CARES, from when the CARES Act was enacted. So things to come on that. We are actively working on our telehealth broadband pilot program, which is basically assessing within 4 states and 25 communities, basically broadband needs and recommendations for moving forward. Currently, we are getting to a point with our partners, TASC, which is our National Telehealth Resource Center for Technology, and our evaluating group, the University of Arkansas, to get to a position to where we identify community partners in the 4 states that we are working in to extend this out. I say that mainly because we're going to try to link them up with the EBB program, but we're also going to try to link them up with the FCC program. And even though EBB is FCC, there's a second COVID cohort that's coming out in the very near future. It's a large amount that FCC just announced, with one of the states that we're serving guaranteed to get 2 awards. So we are actively trying to engage them a little more effectively in so that we can prevent duplication, but be a little more synergistic in our activities. Our broadband pilot program it's small, but it's a 3-year project, basically, that we're trying to see if they get recommendations and to see if it's scalable, to see what the actual needs are in these communities, whether it be wire in the ground, if it's wireless or if it's satellite based. One of the things we are running into, though, is that because there's so much money, and there is a lot of money from FCC, USDA, and NTIA out there when it comes to broadband, it's changing the dynamic in rural. So keeping up with what those changes are is going to be a big thing for us. The playing field is going to be very different in a couple of months, and it will be even more different in a year. So it's kind of a moving target. And so we'll be adapting the program, since it's a cooperative agreement, as we go along. But it's need-based. A big thing about it is that a lot of hospitals and community a lot of communities think they need specific bandwidths, but in reality, it could be that they have the right bandwidth. They're just overusing it with applications that are on it. So it's just a matter of identifying what really is needed. On the general front, we have a number of grants that are open right now. Notice of funding opportunities are out. Most recent one is a Rural Maternity and Obstetrics Management Strategies Program, RMOMS. I know the cohort is out. It's $3 million. It does have some telehealth aspects in its network side of things. It opened up yesterday and will be open through June 4th. We also have the Rural Residency Planning and Development Technical Assistance Program, which opened on the 9th and will be open through May 21st. The Centers of Excellence program that OAT runs is competitive this year, but it's in a limited competition. It opened on 2/19 and closes next week on the 20th. And the difference for this particular program is that we're extending the period of performance to 5 years so that they can do more of their piloting and extending and do a little bit more applied, well, test research, let's just say, that could be used to be scalable for the telehealth resource centers when it comes to technical assistance. There's a little bit of a bump in their award also based on appropriations. And the biggest thing about it is they're moving to more of a national scale. So we are pushing them out of just Mississippi and South Carolina in their operations. Something that's not on our forecast at the moment is a new program that is under development that will be coming out towards the end of May. And that's the Telehealth Technology Enabled Learning Program. It is a ECHO-like learning collaborative program that will be a 5-year program that specifically will try to provide services to train general practitioners in rural areas. It will be partnerships with academic universities. I have to stop there since that's the only public information we've put out about it. But once the NOFO comes out, there will be plenty of information associated with it.
Mike, just say the name of it again. I missed.
The Telehealth Technology Enabled Learning Program.
Yeah, thanks.
Or TELP. So. But at this point, that's all I have. So.
Okay. Thanks so much. As always, Mike, we really appreciate you giving. There's so much going on at HRSA right now. But, okay, we're gonna turn to our broadband update. Jeff Mitchell, are you here? And
I am. Can you hear me? Okay.
We can. Yeah. Hi, Jeff.
Okay. Good. Well, Jeff Mitchell, Fletcher, Hild, and Hildreth. Glad to be back. Hi, Neil. Hello, everyone. So yes, what Michael just said about there being a astounding amount of different funding opportunities out there for broadband, for many things, but especially broadband. It is tough to keep track of it all. I thought I'd try to do that though for you in about the first 5 minutes, kind of recap a little bit about what's happened the last year. Neil touched on kind of what we're looking forward to the next few months with the Biden infrastructure plan. I'll talk about that a little bit, and then I'll talk a little bit about, what the FCC COVID telehealth program. So I'm gonna try to do that in 10 minutes, and I've set my timer. So kind of recapping, as someone who's been really trying to see more funding to broadband for many years now, it's astonishing to see the amount of money that's already been put out there. Just kind of to put it in context, every year the FCC puts out about $9 billion in subsidies as part of its 4 different universal service programs. Lifeline was mentioned, the schools and libraries program, rural healthcare. So that's $9 billion a year that's kind of always going out there. It's kind of gone up over the years. The BTOP program was a very large broadband investment program during the Obama administration. It was about $8 billion, I think, as kind of memory serves. And that was the biggest program we'd ever seen like that to date. The route, so and what we've seen in the last year are 3 huge tranches of emergency spending, round 1, round 2, and round 3. Round 1 was the initial COVID-19 relief package that was passed in March 2020. And that had 150 billion in very flexible relief that was given to the states to deal with anything related to COVID. And many of them used that to augment whatever state broadband programs they had or to launch new ones. And so a not insignificant amount of that 150 billion, the states were actually beginning to invest in broadband. And there's a lot of news stories about states that used the CARES money, the CARES Act money, which was that first tranche for broadband. There was an education stabilization relief fund that was 30 billion that went to the Department of Education. And that also resulted in grants to education, some of which could, in some cases, be used for broadband. So that was the big round one COVID relief about a year ago. Round two COVID relief was in December 2020. And that was where we began to see, well, we saw a significant amount of money go to NTIA, which Michael mentioned, $1 billion for a tribal broadband connectivity grant program. So NTIA is the agency within Department of Commerce that ran the BTOP program. So they've gotten a large tranche of money. They've got 300 million for another broadband infrastructure grant program that's focused on rural, that's not tribal. And then they got 285 million to run a Connecting Minority Communities pilot program. They've been running webinars. I think there might be one still to go this month, but you can replay them. There's 2 webinars that kind of are NTI providing an overview of what their processes are going to be for those programs. The application windows, I do not believe, have been announced. So they're quite busy. They have their plate very full right now, just launching those programs. And that's, 1.5 billion, total. We also saw in the second round of COVID relief from December 2020, more going to the USDA for their Community Connect grant program. I think we saw a little, and then we saw the Education Stabilization Relief Fund, again, a re-up of that, 81 billion this time. And then we saw the FCC getting their Emergency Broadband Benefit program, which Michael also mentioned, 3.2 billion, and then a re-up of the COVID-19 telehealth program, which had gotten 200 million last spring and now got another 249 million. So that's bringing us through December of 2020. And then we saw in March of 2021, the third round of emergency spending, and that was the American Rescue Plan Act. We saw more money going to schools, emergency relief for schools. And we saw an interesting, new program. Well, two things that hadn't happened before. One was a $7 billion plus tranche of money going to the FCC for the E-rate program for emergency spending to help students be connected off campus. And then we saw this $10 billion program actually go to called the Emergency Connectivity Fund, go to the Department of Treasury. And they are in the process of deciding how that money is going to be allocated to the states for them to create grant programs also for broadband connectivity. So that's a $10 billion program authorized in March that's going to be run through the Department of Treasury. And then, the E-rate money. And so it's, these are major programs, each one of these. And it takes a lot of energies to kind of keep track of them. The COVID relief program, the second round of it, as Neil mentioned, the FCC released an order on March 30th, kind of announcing the terms of this. And this is now the 249 million that the FCC has for telehealth. And this is 100% funding. There's no match required if you manage to get your application accepted. And it's last time it was kind of a rolling application window, and a lot of people applied very quickly, and no one knew what was happening. And some people, that it was way oversubscribed, and there was a lot of frustration about people not understanding who was funded and why, and how the funds were distributed. So Congress made some changes when they reauthorized that program and re-upped it with now even more money than last time. And they said every state has to get a little bit of money, and they essentially set it up so what the FCC is going to do this time is have a 7-day application window where everybody is who wants money through this program is going to have to submit their application within that 7-day window. They're going to give everyone 30 days notice of when that window's coming. So they've now, with the release of that order, they've put their bureau staff on notice to release a public notice that will give you notice that this window's coming, but it's going to be a 7-day application window. You're going to get one call back if there's something about your application they have a question about, and you'll have 10 days to sort of respond to that, and then they're going to make their decision. So that's, you know, we'll be looking for an funding announcement of that. So I think that kind of gets us current. And then the last piece is, you know, as Neil mentioned, this new, well, Biden has an infrastructure program that's gotten a lot of press, but Congress already had launched, or at least announced, their infrastructure program, which to some extent is a repackaging of the Lift America Act. At least the broadband provisions of that were. And the Lift America Act was the Democrats' proposal from about a year ago that included an $80 billion broadband component. And Senator Klobuchar and Representative Clyburn have sort of released a bill that is the reworking or the updated version of that $80 billion program. And I think the view is that whatever the Biden infrastructure program ends up looking like, the broadband component of it probably will end up looking a lot like the Klobuchar, Clyburn, you know, package. So, but I think, you know, Neil can probably speak to this better than I, but there's obviously a lot of questions right now about what exactly this package is going to look like in the end. How big is it going to be? How's it going to be paid for? You know, is it going to be bipartisan? You know, and there's a lot of sort of issues coming up. But couldn't find the news article before this call, but John Windhausen mentioned yesterday that he had seen an article that Speaker Pelosi had said that she wants a vote on this in June. So this is on a pretty fast track, and so we're watching it. Yeah, I'll stop there and leave a couple minutes for questions if there are any.
Anything immediate? We may have a minute or two here. If not, you save your questions for the end. As I indicated, we'll try to allocate some time to do that. So thanks a lot, Jeff. We really appreciate it, as always.
I'll go off camera, but I'll wait to the end if there are questions. But
I appreciate that.
Right.
Thanks so much. Okay, for the last 4 years, the National Rural Health Resource Center has been funded by the Federal Office of Rural Health Policy to support rural hospitals and clinics in the Mississippi Delta region. This is not just Mississippi, but 8 states. And it's a multifaceted program that's designed to improve financial quality, performance, et cetera. And we actually get an opportunity to work for 3 years with these hospitals and clinics and try to prepare them for movement into value, population health, et cetera. One of the components of that program is helping these hospitals and clinics implement telehealth and then improve it. And there's even a little bit of funding available to help them pay for equipment as they're putting the infrastructure for their telehealth programs in place. We've been really fortunate to work with the Huron Consulting Group. I think many of you may be familiar with that. Their basic Studer Group is now a part of Huron Consulting. And we have 2 representatives from Huron Consulting here today, Jessica Duke and Donna McHale, to talk to us about industry-based telehealth. And we were talking a little bit in advance. This is sneaking up on us, folks, as we're dealing with all the other crises that are in place. And this movement on the part of business and industry in general into telehealth is moving at a very rapid speed. Mm-hmm. And we thought we'd build in this educational program so that Jessica and Donna can bring us up to date on that. And so I'm going to turn things over to them.
Great. Thanks, Terry. So Jess is going to bring our slides up. And we're excited to talk to you about this. Next, please, Jess. So I'm Donna McHale, and I'm a senior director in our healthcare technology practice. And Jessica Dukes, a manager in our healthcare technology practice. And the two of us, along with our team, run the telehealth practice. And we have been so blessed to be working with Kate and Kim and all of our other friends at National Rural to work on the telehealth projects with, I think we're up to now going to the next round of cohorts. So I think it'll be 30 hospitals. So we've been doing lots of things, as Terry said, and we're just so excited to talk to you about this. So next, Jess. So we're going to talk to you a little bit about the power of telehealth, and then go through some employee-based and industry-based telehealth trends, and then talk to you about something that's very interesting, what some of the big four technology players are doing in healthcare, and then what organizations need to do in order to ride the wave of disruption to get to innovation. And then Jess is going to talk to you a little bit about some of the growing partnerships. So there's some interesting partnerships that are out there with these big four technology companies with some of the healthcare organizations. And then we'll give you some takeaways. So Jess, next, please. So we want to make sure that you understand some of the trends around employee and industry-based telehealth programs, and understand what the different options are to expand telehealth programs. And that's kind of where we're at with a lot of the organizations right now. We've done their assessments, we've helped them select some equipment, as Terry had said, and we've done workflows with them. So now we're helping them really expand their telehealth programs as they're putting them in place. And then understand what some of these big technology companies are doing to start putting their toes in the water with healthcare. And then the partnerships that we talked about, and then what other organizations, other healthcare, easy for me to say, right, you guys, other healthcare organizations have done with their programs. So next, please. This is so much fun to talk about. Healthcare delivery is coming in so many different forms. We're all kind of familiar with Alexa and what an Apple Watch can do, but now there's an Apple Watch that has a one lead EKG attached to it. Smart clothes are coming out, so you can have sensors all over to detect things. Groupon's kind of interesting because there are some providers that are using Groupon to send coupons to patients to bring them into their practice. And Tesla, it's hard to believe, but Tesla, yes, that's a form of healthcare delivery. There's an interesting example where there was a man, he was having a cardiac event, and his Tesla device, his car, was able to understand that he was having a medical issue and connect him with the closest hospital and then drive him there. So by doing that, it saved his life. He was having a pulmonary embolism. And then we're going to talk about Amazon Care. So it's just kind of interesting to see that if you just put these up here, you would say, they're not doing healthcare delivery until you really talk about it. Yes, they are, and there's more coming. So next, please, Jess. So what's going on with the employee-based telehealth trends? It's kind of interesting to see just some of the numbers out there. You know, with the first one, the 300, if you look at some of the telehealth savings, so some organizations have already seen about $300 worth of savings per employee per year, or $1,000 per family of four for a year. I mean, those are big numbers. And then it's interesting too to see this 76% of employers are starting to now expand virtual care and telehealth. You know, people before COVID were all kind of doing a little bit of something, but COVID really sped things up. And we find this so often. It's kind of interesting to see what consumers have done to the telehealth market. In addition to COVID, consumers have really pushed telehealth and virtual care forward. And this is one of the areas that we see is that consumers and employees and employers are looking for telehealth. So they're telling their organizations, we want to see more telehealth. So what you see is that a lot of companies and hospitals and healthcare facilities are now trying to extend their services into things that are a little bit more consumer based, like going into chronic care condition, chronic condition management. So things like giving you some remote monitoring devices so that you can manage the care of your chronic condition at home for like diabetes or congestive heart failure or things like that. But this is kind of interesting. Within 2 years, by 2023, we're expecting the telebehavioral health to grow between 91 and 96%. So Mike, it was interesting to hear you talking about behavioral health, because that's the number one thing that we hear with all of our organizations when they're asking us about what should we start with first. It's telepsych or telebehavioral health. So, we're going to have it almost at 100% growth within the next 2 years. And that employers are looking to expand their virtual care and telehealth by health coaching and emotional well-being support. Again, some of this was already out there, like with Teledoc and that kind of stuff, but now they're looking for different devices to help with that. So next, Jess. As I said, consumers are leading the evolution of telehealth. And this is one of my favorite phrases that every time we give a presentation, Jess and I talk about this, because we want everyone to realize the consumers are going to access care how, when, and where they want it for the price they want. So if you're not providing it for them, they're going to go get it from someone else. So this is really important for organizations to understand. They need to pay attention to the consumers and what's going on all around them in the industry. So next, Jess. So let's talk a little bit about these big technology players, right? So all these names, but isn't it interesting? And you've heard parts of this, of where they're starting, as I said, to dip their toes into the healthcare market. So what's going on here? So with Amazon, for example, you all may be familiar with Amazon, that they have, their web services. So it's a cloud-based service. And then they also have, things like Alexa, where it's, voice activated. And so they're experts in there. So they're trying to use those two pieces to move into the hospital doors to say, let us bring in cloud-based services, as well as let us help you voice activate a lot of things. We've had a lot of hospitals lately ask us how to create a smart room for their patients. And that revolves around those two pieces. And so the other thing that's interesting with Amazon, and Jess will talk to you a little bit more about them in a minute, is that they're using the massive base of employees to test the waters around telehealth. So they have a lot of people all over the 50 states. So that's part of how they're trying to move into the industry. So what's Apple doing? Apple is it's trying to take their consumer products and put them into portable patient healthcare hubs and provide clinical research tools. They've been doing a lot around research, and they're happy to tell us all about all the different cool research that they've been doing. So this is a big area for them. And then Google. Now, Google also has an arm that they call Alphabet. And Alphabet focuses around the AI, the artificial intelligence. And so what they're doing here is very interesting. And a couple of you talked about this already today, about getting to the data and analytics. So one of the things that organizations have been trying to get to is to look at getting to predictive analytics, precision medicine, and interoperability. So a lot of people are using analytics, kind of retrospectively. How did things happen? Why did it happen? But now organizations are trying to get to, how can we predict what's going to happen? So if we know something about the patient, how can we tell whether they're going to become a diabetic patient? And then if so, how can we get to prescriptive medicine, where we're saying, we know what the risk factors are, and Donna, you're at risk to become a diabetic patient. So here's the action we're going to take to keep you from becoming diabetic. So this is where Google's very strong in moving with what they do with AI and the data storage. It's also interesting that they just purchased Fitbit. So now there's a little competition between Fitbit and what's going on with Apple and all the Apple devices. And then there's Microsoft. So Microsoft is really focused on competing with Amazon and Google for the cloud space. So you may have heard of something called Azure. So that's Microsoft's cloud product. And so they're trying to use Azure to compete with Amazon and Google for the cloud space. And really what they want to do is help with the cloud. You know, they're trying to get everybody to move to the cloud. And the reason that we're trying to do that, and not just Microsoft, but everybody, we're trying to get organizations to move as much as they can to the cloud, because then it helps with all the interoperability, because then you have the ability to share all the data that you need to. And so this is kind of what they're doing. So interesting to see what these four big giants are doing on their way into healthcare. And it's really important for healthcare organizations and pharmaceutical companies and other IT organizations to keep an eye on what they're up to. So Jess, how about if we turn it over to you now to take us on a wave, the wave of disruption.
Thanks, Donna. So I think it's important that we need to ride the wave of disruption so that we can find innovation, right? Donna's done a great job of talking about a lot of our disruptors right now. She's introduced us to Amazon Care and Apple and Google, but there's a lot of other disruptors out in the market. You know, we have CVS and we have Walgreens on at the corner of happy and healthy. But what about Walmart? What's Walmart doing out there? There was a lot of talk about Walmart doing, I think it was the $1 or $2 visits for telehealth. But what about, yeah, right. What about Humana and Aetna? What are they bringing to the market of telehealth and how are they disruptors? So there's this concept of sustaining innovation versus disrupting innovation. You know, with sustaining innovation, we have the problem is well understood versus the problem is not well understood. You know, it's existing in the market versus it's new to the market. But the big thing about sustaining innovation is it improves with performance, it's lower in costs, and is incremental in change. So it's easy to take over with that innovation. When it's disruptive, it's very dramatic. It's a game changer. The customer is believable, but then the customer doesn't know when it's disruptive. It makes me think of a toddler when I think of a disruptive innovation. The market is predictable when it's sustaining, and it's completely unpredictable when it's disruptive, just like that toddler pitching a hissy fit. So the traditional business models are sufficient and they're completely failing when it's disruptive. The key thing to remember here is we're retreating from innovation is not an option. And I love that quote. So moving forward, I want to dive a little bit more into Amazon Health, kind of thinking about what they're doing right now. A lot of talk is out there about Amazon Care. So telemedicine, I can't talk either, Donna. Telemedicine and primary care services. So they're in the market for their employees right now, their employees and their dependents. For the summer of 2021, they're talking about expanding into all 50 states. It's a huge game changer. It's very disruptive. Their services will include in-person urgent care and primary care services, and they have multiple engagement tools to deliver those services. They're talking about doing follow-up care. They're talking about COVID testing. They're talking about even immunizations. That's how they're disrupting the market from the telehealth perspective. There's also this whole direct-to-consumer partnership that they have created with Healthcare Advisory Network. So this is a zero copay telemedicine visit with free prescription drugs. So that's one area that they've gone into. Then there's this whole other area with Pittsburgh Health Data Alliance that they've expanded with their partnership with their AWS service line. And this is a whole area with new machine learning models, and it's to help detect breast cancer and depression early detection. And then they have had this partnership that they've created for hospital to home. And it's a huge network of different Ascension, Dispatch Health, Intermountain's involved, Landmark. There's several organizations that are wrapped into this. And this huge initiative is to focus in on changing reimbursement models and then certainly culture around the whole institutional care. So they're trying to drive the care home, and then certainly they're going to enable Alexa, voice recognition, but they want to get that reimbursement component wrapped into it. So you can kind of see where Amazon's driving their health model. They also have gotten in with Best Buy Health. They've launched a flip phone directed towards senior citizens, and they went ahead and enabled this with telehealth capabilities to help connect those senior citizens with telehealth services. And then last but not least, they partnered with Christiana Care to do a home health dubbed service line, once again enabling with Alexa to do customized health plans, care plans, so that Alexa can be enabled to ask questions back to the provider to enable that home health care model. So a lot going on with Amazon. They're definitely laying down the roots to get their health service going. If you think about Apple Healthcare, they've definitely been in the market for a while. There's kind of talks on that they are going to be making bigger movements soon. They've partnered with VA for a while now. They've actually put out 50,000 iPads to veterans to improve the access to care and to help with that digital divide with veterans. Another concept that they've done is with EHR vendors. They've partnered with Epic, Athena Health, and Cerner to allow patients and providers better access to their EHR records, enabling it with their technology. Another partnership, which I thought was really interesting, was with Duke University School of Medicine and with Stanford University hospitals. So they're enabling the chronically ill patients. So they've connected those universities with the Health Kit platform. So they've done the remote patient monitoring through the Health Kit platform. And the feedback that they're getting from both those universities is very successful. Another partnership is with Ochsner Health, which a lot of the Delta hospitals have connected with Ochsner through their OBAR. So the patients go to the OBAR, they connect to the devices. So that's a way for a successful adoption. And then that information is fed back to their platform through the Apple Health app. And they also are using Apple devices to connect all that information to the EHR, which I think is epic. And then another partnership is with Johnson & Johnson for early detection of atrial fibrillation with Johnson & Johnson's care coordination app. So a lot of partnerships happening with Apple. The big controversy with Apple is whether or not they're going to jump into a true healthcare realm because of the FDA regulations associated. So Google Health, another big tech that hasn't really completely expanded, but they're definitely expanding through AI, like Donna was talking about earlier. They have a pilot project with HHS right now. They've developed a tool for tracking or for patients to be able to document their questions and then report it back to their providers. So they basically are documenting their questions and they transmit it back to the provider's office. And then the provider has the questions that are prepared for the next time the patient has an appointment. Google and Apple actually partnered together to detect when users are close to someone who has tested positive for COVID. That was back in 2020. Then one of the big things is Google has invested in Amwell. We all know who Amwell is, one of the big powerhouses with telehealth. And this is for AI and machine learning technologies. And they want to automate the waiting room and checkout process. Another piece of this puzzle is translation services, which would be huge for telehealth because it is one of the big kind of the missing pieces of the puzzle. Google Health also has launched an app to connect individuals to clinical studies. And this is something that's happening with Harvard Medicine and our medical school and Boston Children's. And then they've had partnerships with Mayo Clinic for AI. And then Google has a venture arm that has led a $100 million funding around Vera Health for a tech startup that analyzes clinical data for ophthalmology and neurology care. Can't get the words out of my mouth today. So this is a really interesting quote that I thought would be good to share because I like the perspective of it. So the first part of it is talking about a lot of different companies are trying to consumerize because we talk a lot about consumerism right now. So they're addressing the patient in the home with remote devices, like we've talked about, the Apple Watch, but they're combining the devices like Alexa and others. So people may start trusting their physician and hospital as one voice of many in the care opposed to the voice they trust. So that puts pressure on clinics and hospitals because they don't easily have the means to share and consume data. So if you think about it, the hospitals do have pressure because they can't exchange the data as quickly as some of the big tech companies do. So what this gentleman is saying here is one of the best allies that you can have is Amazon or Microsoft or Intel, because they can manage that data as quickly as hospitals aren't able to right now. Just thought that was very interesting. So where do we go from here? I think the healthcare ecosystem is very important and we need to partner for progress. So if you think about the ecosystem, you have the healthcare system, you have the technology and data experts, and then you have pharma. So then within this whole ecosystem, you also have the payers, the providers, the retail and grocery. So if we think about digital health collaborative partners, sometimes they can be unique and surprising, like Amazon, like Google, or Apple. So we will need to be key to optimizing healthcare by looking at those surprising partnerships. And thinking towards those partnerships, there's been some really interesting ones that have come out to play. So Baptist Health actually partnered with a home developer, CC Homes. And what they did here is with their CC Homes, when they built the new houses, they provided free virtual healthcare services and digital exam kits to all new home buyers. So they put those into the new houses for the new home buyers. Now, a Cleveland-based university hospital actually partnered with NASA. They created methods for decontamination of PPE for aerospace applications and COVID-19 frontline workers. So that was a unique partnership again. United Airlines tapped Cleveland Clinic. They requested advice on social distancing protocols during flights. And so the CEO for United Airlines, he said, look, airplanes aren't meant to have people 6 feet apart. So we need some help with this. And that's where their partnership came from. And then Emory Healthcare partnered with Verizon. They wanted to test the 5G powered healthcare devices, which included connecting on the ambulances, medical imaging, and the remote physical therapy. So that's where their partnership came from in Atlanta. And then Common Spirit Health partnered with Palladia Health to offer a direct consumer primary care across 137 hospitals in 21 states. And their partnership will provide services at clinics in Las Vegas initially, and then they'll expand out from there. So some little bit different partnerships moving out. And then I could not leave this presentation without jumping into Uber Health, because are they a healthcare disruptor or are they the biggest ally? And I think Uber Health could actually be one of the biggest allies for healthcare. Providers could schedule ride shares for patients. They can get some real-time GPS tracking. If your patient isn't showing up for a visit, hey, let me just track them and find out where they actually are. You can even message the driver to say, is my patient coming or not? And it can be HIPAA compliant and available on desktops and mobiles. And let's be real about this. One of the biggest social determinants of health is transportation in our vulnerable communities. So I think it is one of our biggest allies. I believe this is you, Donna.
Yeah, well, thank you, Jess. You know, it's kind of interesting to see what is going on and how disruptive things are going to get for our healthcare friends that we're working with, because it's coming from every different angle, as Jess said. So as we talk to organizations, like we said earlier, we talked to them about it's really important for you to own your future or you're going to be disrupted by it. And it's just doing some very simple things like understanding what problems you're trying to solve and how you're trying to get it done. There's a lot out there, as you can see, there's a lot of technology out there to help, but you really just can't sit still because this is just going to go right by you. As we talked about that at the beginning of our call, that this is moving so fast. So it's really kind of your time to, I usually use this as the mic drop, take it and own your future. So next, Jess. So what are some things that we want you to take away? Of course, we want you to take away our favorite sentence about the consumers and how they're going to access their care, when, how, when, where, and for the price they want. And if they don't get it from you, they're going to get it from someone else. And be aware that care delivery comes in many different forms. And that your next competitor may also be your partner. You know, we had an interesting discussion with one of our CEOs, and we talked about some of these as competitors, but then we also said, you know what, they may be opportunities for you to partner with them. So you've seen some examples how other organizations have partnered with these organizations. And so it may be something to be thinking about. And that employers see virtual care as a very significant part of their healthcare delivery, and that they want to grow it beyond what they're doing right now, and to look at how you can manage your chronic care conditions at home for behavioral health, occupational health, all with remote monitoring devices. And that you can expand your telehealth services to industry-based telehealth programs, and to really understand how the partnerships are changing. They're out there. And as you can see, the companies are willing to work with hospitals. They're trying to get their feet in the doors of lots of different organizations, large and small. So, you know, now's the time to think about that and be ready to ride this amazing ride, the wave of disruption to innovation. So with that, we'll see if you have any questions. No.
Thank you both. I have a question, but does anybody in the group want to weigh in with a question here?
I have one, but I'll wait also, Terry. Go ahead.
Okay. Well, let me ask mine then quickly here. And then besides these other competitors, we also have something called a hospital at home program that is being developed by, in fact, has been developed by Geisinger, by Mayo, et cetera. And the reports that they are coming back about doing acute care in the home setting is really pretty astounding. It's saving money, cost savings 19 to 30%. They say better clinical outcomes, greater patient satisfaction, family satisfaction, et cetera. So there are no longer these geographic distances that used to keep our rural communities or our rural hospitals and clinics safe from the outside. These are competitors that really are going to be kind of in their back door as such. So do you have any more information on that in terms of that hospital at home program?
Yes, we're actually doing quite a bit of work there. So in two veins. One, we're partnered with a company called Medically Home. So they're based out of Boston. And what Medically Home does is, and it may not be applicable for the size of our rural hospitals, but for some of the larger academic medical centers, what they're doing, in some community hospitals too, they set up a command center. They have a command center in their Boston office that runs 24/7, and it has all the clinicians and providers there. And so then what they do is they provide, I think they're up to about 20 different diagnoses that they would do the care plan for at home. And so what it's focused on is trying to keep the readmission rates of the 30 days down. And so once you get to the ED, if you meet the criteria for these 20 different diagnoses, then you are put on a different track so that you never go upstairs, you're never admitted. So once you're taken care of in the ED, then you're discharged to home. And then they have 2 SWAT teams that follow you home. One's the clinical SWAT team and the other is the IT SWAT team. So the IT team comes in and sets up all the technology that's needed, which is not a lot. It's an iPad, making sure your internet's stable, and then your remote monitoring devices. And then the clinical team comes in with the care plan that you need and any other supplies that you need to take care of your care at home. So then we're also looking at, because like I said, not every organization needs that big command center type, but what we also are doing with some of our hospitals is just helping them set this up so that they can do the acute care at home. You know, a lot of times things like post-op surgery, there's a lot of great use for that that organizations are looking to do. So they don't need that whole command center, but we're doing a lot in that space because you're right, Terry, it's a big area and there's so much savings and the patient is so much happier to be recovering at home.
Thanks.
You're welcome.
Neil?
Yeah, thanks so much, Donna and Jess. Really a lot to think about and contemplate. And it's like drinking from a fire hose, which goes to my comment, which I hope doesn't sound at all pejorative, because I think there's a lot here.
Mm-hmm.
The issue is separating the wheat from the chaff,
Mm-hmm.
time, and the real level of commitment of these major corporations in terms of what their higher ups and their PR departments claim to and say they're going to be doing.
Yeah.
You can take the Amazon, Berkshire Hathaway, you know, JP Morgan partnership, which was going to change the world up in the Northwest, and that kind of fell apart. Or in the health sphere, you can have gone to 25 years worth of HIMSS meetings and ATA meetings and seen people come and go and
Oh yeah.
broadcast or not, AT&T, Verizon, IBM, and they're all involved.
Oh yes.
So, but not in the way they originally said they were going to be. Hewlett Packard, ADT Security, you name it.
Yeah.
Every major company that has anything to do with technology has put a stake in the ground, a bunch of lines in the water, and waited to see kind of what happened without making a real major commitment to some of the programs, especially that drilled down into, right?
Yes.
And, you know, I started to track for Bipartisan Policy Center when I was there about 2 years ago. The companies involved in Internet of Medical Things and AI.
Oh yeah. Oh yeah.
I'd be curious to know how many are still sort of actively involved. My point here is we've got to know on sort of the pilots as these things continue, and maybe you guys are going to be able to do this, I think. Back what's real and what's not real, and kind of commitment they maintained in association with the Cleveland Clinics and the Ascensions and the big rural healthcare institutions and all the rest. We drill down to it because it's just too much. It's just happening too quick.
It is.
With too many commitments, and you know, some will and some won't last.
Yeah.
Absolutely.
Yeah, you're absolutely right. And we are keeping track of that. You know, it's kind of funny.
Good.
One of the things that I was reading too was like that Google's trying to develop their own EHR. And I'm like, oh, good Lord, you know, how many things are they going to try to get into? You know, so we are trying to keep track of what's real and what's not. And, you know, it's important for organizations to know about this stuff and to be thinking about it. You know,
Right.
like,
Absolutely. Absolutely.
You know, go ahead, Jess.
I was just going to say, I think that another point that has to be driven is the quality of the care.
Yes.
And how that's going to be measured for these visits.
Yes.
You know, I was on a call earlier with Brock and John, and I think that that's a point that really has to be driven over the next year. If this continues, is what's the quality of those visits?
Yeah.
And how is it going to be measured?
Yeah.
If you look at just some of their top people and you see how they come and go, and I won't
Right.
names from some of those companies, some of us know who some of them are and have been.
Yeah,
It's, you know, it's a bit of a revolving door there too.
Right.
it is. It's interesting. Yeah, because you have to put the wow factor aside and go, wow, this is so cool. And then you have to go into reality and say, how can I implement this? And so what is real and what's going to be here longer term? So we agree with you. And we are keeping track of that too.
Great, great. Thank you so much. Thank you.
Oh, you're welcome.
And what I would say is, since this is so financially driven in many ways,
Mhm.
is the quality of care really going to matter that much in that regard? Because, I'd much rather, we could argue that going to your local store in a rural community is the better way to do this, is better for the community, et cetera. But price drives so much of this.
Mhm.
And there is this whole issue of continuity of care. So
Yes.
if you're a rural person, like I'm kind of rural, I live over 20 miles outside of Duluth. It's
Mhm.
great to have this. I mean, if we think about it from a consumer standpoint,
Yeah.
I love the fact that I wouldn't have to drive, an hour and sit in an emergency room for certain periods of time. So I think this double-edged sword, whether we like it or not, is going to be here. And I think, one of the things we can do, and I think that's what you guys are saying, is that we've got to get our rural hospitals and clinics aware that this is going on. And they could be selling quality, they could be selling continuity of care right now, because the convenience of this and the economic advantages for companies and employers, to me, may trump the negativity of some of the quality breakdowns.
Yeah, the other part too, you guys, is that why we're really focused on it when we're working on our rural hospitals is the fact that it breaks down some of these inequities. So, the biggest inequities, and we've talked about it several times today on the call, is about broadband. So how can you use broadband? Just brought up one of the areas that they're looking at putting stuff on the ambulances. So so many of our organizations here are 2 hours out to a hospital when they're transporting and 2 hours back. So what can you do to mobilize those ambulances with the technology you need, and really trying to bring the care to the home of our patients, our rural patients. We need to be able to get to them. So what does it take? What are the inequities that we need to break down? What barriers are there so that we can get to them? So whether it's at the community or a shelter or a library, whatever it is, how can we get there? So that's where we're kind of looking at some of this cool technology to help us do that.
Yeah.
There's been talk in Washington about bringing back an Office of Technology Assessment that had existed, for example, when 30 years ago when I worked on the Hill, and blah, blah, blah. And also beefing up the Office of Science and Technology Policy
Yeah.
in the White House. And to the credit of the last administration, they had begun to focus on AI and machine
Yeah.
through some of their staff and things. But I think, some of this kind of discussion almost needs to be bumped up, given just this to that kind of level. So there's some, focused funding behind assessing where it's all at and things like that.
Exactly.
Commerce Department, NTIA, or wherever, but policy folks are going to have to really, kind of help move it along, give some reference to it also, I think, at some point.
Okay, you were going to have to close here. I want to thank Jessica and Donna for being here, and all our other speakers. Jeff had to leave. If you have questions for everybody here, anybody, just why don't you send them to us? Jeff has left an email address. Lisa from Pennsylvania basically asked if there was one kind of concise site for getting all this information, because there's so much going on the telehealth and broadband side of it. So if we can find something like that, let's try to make it available to our coalition members. And I think with that, you can send questions, task@ruralcenter.org, and we'll find answers or make connections. Thank you so much for what I think has been a really stimulating conversation, and we'll see you next time. Bye, everyone.
Bye-bye.
Bye.
Take care. Thanks, Terry.
Everyone.